Morning, everyone. So I'm going to talk to you today about blood grouping, antibodies and pregnancy. And when I agreed to do this, I had a particular midwife in mind who would always say to me, "Jo, I know you always tell me about antibodies and antigens and everything." She said, "But once you've gone out the room, I've completely forgotten it." So I'm going to go back to basics. So for any scientists in the room, you can have a little snooze now. But we're going to go back to basics. So the history of blood transfusion. The history of blood transfusion, it's been a bit of a checkered history. As you can see from some of these rather gruesome pictures, there's been transfusion directly from donor to recipient, from animals to humans. But they always knew that sometimes it worked, sometimes it didn't. And it wasn't until this rather dapper chap in the corner there, Karl Landsteiner, he was an Austrian-born biologist and physician, and in 1901 he did a lot of work cross-reacting red cells from donors with plasma. And he really was the first to discover the four major blood groups, A, B, AB, and O. Unfortunately, at that time, though, it wasn't really recognised, his work wasn't recognised until about 1909, when he did actually finally prove that if you transfused someone of the same blood group, then the reaction didn't occur. And he actually ended up winning in 1930 the Nobel Prize for this really important work. And of course, at this time, where we didn't know about blood groups, maternal death was extremely high from postnatal hemorrhage. So this is why his work is so important. So, let's go back to basics around blood groups. What are blood groups? So there are antigens on the red cells. They're just protein. We're all made of protein. They're sugars. And they have particular shapes, if you like. The A antigen is one shape, B antigen is another. That's what makes you A or B. If you carry both antigens, you're an AB. And if you're an O, you have neither of those antigens on your red cells. But that's not the whole story. Because in the plasma, there are antibodies. And these are naturally occurring antibodies. They're not there at birth. They start appearing at about 4 months old. And we think that's where we're exposed to various proteins with similar shapes. So we make an antibody against what's not self. And those antibodies in the red cell, in the plasma, if you're A, you have anti-B in your plasma. If you're B, you have anti-A. If you're AB, you have none. And if you're O, you have anti-A and anti-B. Simple. This is the basis of blood grouping to this day. These are the reactions that Landsteiner in 1901 was observing, and we are still using that today. So, obviously today we have commercially produced antibodies and cells that we use to, identify blood groups. But essentially, those reactions that he was seeing in his tile, very much like that tile up there, are the same. Antibody attaches to a red cell antigen and they agglutinate. However, today we're a little bit more sophisticated than tiles. And we use large machines that can group hundreds of samples a day. Other machines are available. So, rabbits and monkeys. Bet you didn't think you were going to talk about rabbits and monkeys. So Landsteiner again, with a colleague, Andrew Weiner, in about sort of towards the end of the 1930s, 1937, he injected red cells from a rhesus monkey, there's a clue in the name there, into rabbits. He then extracted the antibodies from the rabbit's serum, and he found that that antibody reacted with about roughly 80% of human red cells regardless of their A, B or O grouping. So he had in fact discovered the rhesus group system, which we now call RH. So let's talk about positive or negative then. Again, the D antigen, it's just a structure on your red cells. If you have that D antigen, you're RHD positive. If you lack that antigen, you're RHD negative. However, anti-D, so the antibody to the D antigen, is not naturally occurring like anti-A and anti-B. You can only make anti-D by being exposed to the D antigen and making that antibody. And the only way you can be exposed to that antigen is via a blood transfusion or via pregnancy. So now we've got blood groups established, I'm going to give you another history lesson. History of hemolytic disease of the fetus and newborn. So, I was really shocked at this, but it was first described actually in 1609 by a French midwife. And she delivered twins. The first twin was born very swollen and died soon after birth. And the second twin was very, very jaundiced and died a few days later. And for the next nearly 300 years, this phenomenon was noted. They knew it happened, but nobody knew why. Nobody knew the mechanism. Then, in 1932, Louis Diamond and his team recognised this phenomenon and called it, I have to write it down because I can't remember, erythroblastosis fetalis, which is a bit of a mouthful. But they basically recognised the relationship between antibodies in the maternal circulation and fetal red cell destruction. So the anemia, the jaundice, and the hydrops was all to do with fetal red cell destruction while still in the womb. So then, in 1937, Landsteiner comes along with his rabbits and monkeys, and the rhesus group is discovered, is identified. Then we jump almost a decade, or perhaps more than a decade later, and a chap called Bruce Chown recognised that the link between the alloimmunisation of mother and hemolytic disease, he recognised that link, and he said that the cause was a transplacental hemorrhage. So they now knew that fetal cells were leaking into the maternal system and causing sensitisation. I'm sure you'll all know this name. So Mr. Clyhauer and Becht, in 1957, so before we even have anti-D, the Clyhauer was born. And they used a method of acid dilution. It's exactly the same method that we use today in all our blood banks to quantify the number of fetal cells within the maternal circulation. We obviously do have more sophisticated flow cytometry tests now to find the size of a feto-maternal hemorrhage, but this is still the standard screening test. Then we move on to the 60s. It's not quite within my lifetime yet, but the USA and the UK were doing some work around looking at therapeutic antibodies to try and remove these antigens from the maternal circulation, and hopefully their theory was that they would stop mums immunising with anti-D. And the first anti-D was administered on May the 29th, 1968, just a year before I was born. I'm trying to work out how old I am now. So that was quite a step forward in the treatment of hemolytic disease. Then we move on to the 1970s. Routine antenatal care was very good. It started to incorporate screening women who would be at high risk from having a hemolytic disease baby. So we did their blood groups and we screened them for antibodies in their plasma. And they were given anti-D for any potentially sensitising event and for post-delivery of an RHD positive baby. And this is where it's a real success story. You can see there that pre-1969, 1 in 2,200 births of babies died of hemolytic disease. And then you look at 1990, RHD alloimmunisation, it was 1 in 62,500. So in just 20 years, the serious HDN and the death rate had gone right down. So it's a really, really good success story. But we didn't rest on our laurels. It was discovered that even with immunisation, anti-D, 18 to 27% of cases of hemolytic disease, of alloimmunisation occurred in the 3rd trimester, usually of the first pregnancy, without any recognised event, so no obvious bleeding, no obvious trauma, and they were still immunising. So, and this is about the beginning of my career in biomedical science, routine antenatal anti-D prophylaxis was born. So women at 28 weeks originally had 2 doses of 500 international units at 28 and 34 weeks, and then recently, in the last sort of 5 to 8 years really, we get much better compliance with a single dose of 1,500. And now, since 1983, around 50% of antibodies in pregnancy are actually not D. So that really is quite a good success story. This is the next step. So in the last couple of years, the cell-free fetal DNA test has been available. So we are now able to identify RHD negative women who are carrying an RHD negative baby and therefore do not need their anti-D. So instead of blanketly giving injections to women, which is a blood product, we can now reduce that, and only those who absolutely need it get their anti-D. And I'd just really like to share with you a lovely, we've just started doing this, and we had a lady who was 30 weeks pregnant. She'd been bleeding intermittently on and off for weeks. She'd had about 10 anti-D injections, and they are very painful, so I'm told. She had very sore arms. So we sent off the fetal DNA, and her fetus was RHD negative. So I was very excited. The midwife I gave the result to was very excited, so we both went to tell her the good news together. And she was really pleased that she didn't have to have any more anti-D. So that's a really good success story. But of course, anti-D is not the only antibody you can have in pregnancy. There are others. Clinically significant antibodies. Here are just some of them. I'm sure you recognise the names. The ones we're really concerned about these days are little c and big K, or Kel. But they have to be managed during pregnancy because we can't prevent these. So how do we manage them? Well, the lab, the local transfusion lab, identifies the antibodies during routine antenatal screening. The samples referred to their local red cell immunohematology laboratory, and they work their magic, and they teeter it or quantify it and give us the results. So the results determine then the frequency of testing. So we're very much led by them, and the monitoring of the baby is either very conservative by ultrasound or the more aggressive, depending on how high the titer level is of intrauterine transfusions. But that's how we can monitor those ladies now. Here's a typical NHSBT report. They're very good. You have exactly what the antibody is and what the risk is. There's some clinical advice. Should she be in the care of a hospital obstetric unit or a specialist unit? How sampling, how often you should repeat the sampling, And any further actions at delivery, and then there's a little note for us in the lab at the end, what kind of blood we need to give that patient should she require blood at delivery or during her pregnancy. So it's all very well set out for us. This one, I just wanted to share with you a little story about this one, because it shows, because this has been so successful, we do tend to forget really bad cases of hemolytic disease and how to deal with them, because we don't see them anymore because it's been so successful. So this was a very young, early 20s lady who had, amongst other antibodies, anti-D. This quantification of over 76 was just towards the end of her pregnancy. It was the first pregnancy with our hospital. And obviously there's a very high risk of hemolytic disease here. So she delivered at the local hospital, but people weren't really sure what to do. They knew the baby perhaps needed an exchange transfusion, but mistakes were made around that. Luckily the baby was fine, but it made us put into place procedures for if we ever came across this again. And thankfully we did, because only a few months later she was pregnant again, and her booking titer was over 70. So everybody, it was all in place, what she needed to do. She was at a fetal unit, she was seen up at a specialist fetal unit, but she did deliver that baby at the local hospital again, and her pre-delivery quantification was over 100. So everybody was prepared, they knew what they needed to do with the exchange transfusion, but thankfully the baby actually didn't need an exchange transfusion at that point and was fine. So it just shows that we don't see it that often. We need to make sure our processes are robust. So this is just a little bit about exchange transfusion, what it actually does. It literally replaces blood with blood that's compatible with mum, in order to lower the serum bilirubin, take away baby's affected red cells, remove mum's circulating antibodies, and to correct anemia. We get them directly from the blood centres. They do expire in 24 hours. This is why you need to coordinate really well, because if you order it, you've got 24 hours to use it. And it's usually cross-matched against mum's sample. So, I've rushed through this a little bit. My last slide really is to make you think about at delivery. Up to this point, we've been focusing on the baby, getting the baby safe and well to delivery. But what happens if mum bleeds at delivery and she's got antibodies? From what I said at the beginning, maternal death used to be very high before we had transfusion. And now, if a lady bleeds and she's got a complicated antibody, we need to make sure that we have blood in stock for her. So where I work, we have a care pathway that instructs people how to, what to do at what point, and when she comes in to deliver, the lab is immediately alerted that this lady is in. They can then order in or squirrel away some units in the back of the stock fridge specifically for her. They won't be used for anybody else until she's delivered and gone home. And that came out of an incident that we had a few years ago now, where a lady did bleed and there was no compatible blood for her. So don't forget mum at the end at delivery. So thank you for listening to me, and enjoy the rest of the day.